Thank you, Caitlin, for that introduction. As Caitlin said, my name is Dr. Almeida, and we're going to learn a little bit about Parkinson's disease today. I am putting the slide up to start with just in case you need contact information. So if you're looking to get a hold of us, I'll just draw your attention to the bottom of the slide. The bottom of the slide is our phone number as well as our email address, and if you, it'll pop up a couple different times during the presentation. Okay, so let's start with the initial naming of the disease. Parkinson's disease was initially described in 1817, over 200 years ago, by Dr. James Parkinson. And here you can see the front cover of the essay that he would have written describing what he called the shaking palsy. The shaking palsy, of course, we now call resting tremor. But the basic idea is that Dr. James Parkinson had noticed that several of his patients were showing this type of unusual tremor after a bout of viral disease. What it looks like anatomically is more like this picture that we would see here. And what we have is parts of the brain that are deep in the center of the brain. You can think of them almost like nuts in the center of a peach, where some of the structures start to degenerate over time. So if you look at the left side of the slide, what you can see is this is part of the brain stem on the left side, and you can see that there's a black kind of rainbow shape that you can see there. That's called a substantia nigra. And over time, those neurons of the substantia nigra, which produce dopamine, they start to degenerate. So if you look just to the right at the brainstem, you can see that that black striation is no longer there, and that hints to the fact that there's some degeneration or loss of those neurons that produce dopamine. Okay, so with the death of these dopamine-producing neurons, of course, we have a shortage of dopamine for the entire brain, but primarily the basal ganglia. The basal ganglia are these structures that you can see in this picture are outlined in green. And the green is supposed to represent a very central part of the brain that is important for motor control, and hence, if it's not functioning properly, we end up with motor dysfunction. So some of the cardinal symptoms of Parkinson's disease are the ones that you see here. The first one, as described initially by James Parkinson, is tremor. And the tremor in Parkinson's disease is, we describe it as a resting tremor. Resting tremor means that it happens predominantly in the hands, usually on the one side of the body before the other side, so we call it a unilateral tremor. And the tremor is generally seen at rest. That means that when our hands are resting in our lap or on a table, you might start to see the thumb or one of the pinky fingers start to resonate back and forward. And generally that tremor, the interesting thing about Parkinson's tremor is that if you raise your hands up or if you start to do something functional like holding onto a mug or carrying a plate or something in your hands, then usually that tremor disappears. And so that's why we call it a resting tremor. And as I said before, that is the original symptom that James Parkinson was describing in some of his patients 200 years ago. In addition to that, now we do have other symptoms that are considered the cardinal symptoms of Parkinson's. The second one that's commonly seen is rigidity. Rigidity is just a fancy name for stiffness or co-contraction of muscle pairs. So often patients will not be able to detect this themselves, but if you check your range of motion and how you can move your arms or your legs, or most often in the neck. People, for example, will describe that when they're checking their blind spot when driving, that they notice that they can't turn their head as far back as they used to be able to. Clinically, it requires the assessment of somebody who's trained to assess rigidity, and it's much more easily detectable by that person who's doing the assessment, like your physician. The third symptom of Parkinson's, of course, is bradykinesia. Bradykinesia is a fancy word for slowness of movement. And slowness of movement can be detected in several places. Of course, it can be noticed in how you're using your arms and your hands. So slowness in doing up your buttons on your shirt, getting your arms into and out of sleeves in your jackets or sweaters, your ability to use a knife and fork to feed yourself, all those sorts of activities would be notably slower than if you didn't have Parkinson's. Bradykinesia can also be seen in the lower limbs in the sense that when you're walking, the pattern of walking is smaller stepped, slower velocity. And we also do see it in speech. And so in terms of speech, speech can be slower, but also notably quieter than your normal volume. And often patients with Parkinson's don't recognize that they're talking quieter, but a lot of people will ask them to repeat whatever they're saying. The fourth symptom on here we're going to talk about in a tiny bit of extra detail on the next slide is akinesia. Akinesia means the lack of voluntary movement. And sometimes we associate this term with the word freezing as well. Akinesia as lack of voluntary movement basically means the inability to voluntarily control muscles. So with Parkinson's, sometimes you lack facial expression, and that's because of the inability to flex the facial muscles into a smile or to raise the eyebrows if you're excited about something. Akinesia can also be noted in the feet. If people are trying to walk, then sometimes they report that their feet feel like they're stuck to the ground, and we'll talk about that, as I said, in a moment. The fifth symptom on there is postural instability. So this relates to balance impairment, your ability to use postural reflexes to keep yourself from falling. And they're not completely absent in Parkinson's, but as the disease progresses, of course, these symptoms of balance impairment start to become worse. In addition to these cardinal symptoms of Parkinson's, we do have secondary issues that we always try and consider. Sometimes when people are walking slower or having difficulty standing up out of a chair or using their hands, potentially looking like they're more fragile, we might relate that to weakness or a force production issue. Maybe they're not using their arms or legs as forcefully as they normally would. We also think about things like fatigue, pain, and the potential for inactivity leading to cardiovascular decline. We'll talk about some of these non-motor symptoms in a moment. Before we do that, let's just deal with freezing of gait, which is, as I was describing before, akinesia or a lack of voluntary movement. This does not happen in all patients, and in fact, it's fairly unpredictable as to whether or not you should expect to see this symptom at all. Patients that do experience it, it tends to be at the later stages of the disease, and the patients will describe as if they feel like their feet are glued to the floor, almost like their toes are stuck and their knees start to tremble on the spot because their knees are trying to lift them up, the feet off the ground to be able to take the next step. But for whatever reason, the feet feel like they're literally nailed or glued to the floor. There are certain places where this is most common. Certainly it's most common when changing directions or during sharp turns. During the initiation of movement, we can often see a little bit of hesitation before the person actually takes that first step. We also do something called a dual tasking procedure, which means that when we perform multiple tasks, like counting backwards or perhaps talking on your cell phone while you're actually walking, we might anticipate an increase in the amount of freezing of gait or walking. And walking through narrow doorways, which I'm going to show you in just a moment on a video. Any sort of sudden demand or change in focus of attention can potentially cause this type of freezing. So here's one very simplistic example, and what you're going to see in this video is the idea of walking through a doorway. This is a participant who's walking through a double wide open doorway in our rehab gymnasium here at our research center. And as you can see, the person walks through the door fairly comfortably when both of the doors are open. Now all we're doing is closing one of the doors. And if you watch the video now, just as he passes through the doorway, the person will start to become stuck right at this point right here. And that's simply because one of the two doors is closed, so it's not as wide open a space. And in this third video, we've narrowed the doorway just by 6 inches. You'll notice there's a plank on the right side of the door frame to make it a little bit more narrow. And notice that the freezing or the locking of his feet happens even earlier. Now, the underlying mechanisms of why this happens is really poorly understood, and it's one of the things that we focus on in our research. But at least you've got the idea as to what really happens with the feet. Here again, you can see this person getting stuck before the doorway, and of course, if the wall wasn't there, this person probably would have fallen. Okay, so the one thing that I do want to do, and I'm not going to go through all of this research, but I will show you the basic idea of what happens if we try and deal with some of these issues. Freezing of gait is one of those problems that unfortunately doesn't respond well to the medications, and we'll be talking about the medications in the next part of this talk. But generally speaking, freezing of gait doesn't seem to respond all that well to medication, and the response to medication is quite variable. So what I'm going to show you is this very simple idea of what happens to somebody who's freezing. And in this video, what you're going to see is that there are lines, black lines, that are there basically as targets for the feet. And if we ask the patient to focus on those targets, you'll see that his walking is actually quite good. So I'll play this video. And you're seeing two views here, one from the back and one from the front. Okay, so if you notice the person with those lines there, you can see that he walks almost like normal. Now I'm going to play the same person again. This video on the left, now you'll see that those lines, the black lines, are gone from the carpet, and watch how much his walking changes. Already you can see smaller steps, and eventually, right about here, you can see that he's basically teeter-tottering on the spot. His feet are locked, the toes seem to be glued to the floor, and he's still trying to make his way to be able to get those steps out. This actually isn't a frozen video. He's still trying to move at this point. And there eventually you can start to see him making his way to the doorway. So again, a very simple idea of just adding lines to the ground like this is something that you can do within your own home environment, or even if you're out in public, to give somebody a target to try and step towards. It helps them get out of this freezing behavior. Now let's focus on some of the non-motor symptoms of Parkinson's. One of the most common, and as you can see here, there's a list of symptoms, but one of the most common ones that has been linked to Parkinson's disease is the loss of sense of smell. This has been described very well in the literature over the last 20 years by Brock, and the idea behind this is that, in fact, some of the loss of sense of smell may precede the actual motor symptoms or movement symptoms of Parkinson's. In fact, many of the problems listed here, numbness and tingling, difficulty sleeping, constipation and urination issues, many of these symptoms may actually precede Parkinson's, and one of the challenges is to try and figure out, do we brush these things off as part of old age, or is this truly symptoms of Parkinson's? It is important for us to be aware of these symptoms, because when they start to show themselves, it is important to report that to your doctor so that we can make sure that we've got an appropriate diagnosis. Numbness and tingling, as the second bullet point on this slide, hints to the fact that in some cases, maybe your limbs are hinting towards what might be the start of a tremor. So it's always important to pay attention to that. Difficulty sleeping, REM sleep disorder, even restless leg syndrome, where your feet feel like they're jumping or kicking while you're sleeping, is a common problem associated with Parkinson's. Constipation and urination issues are certainly common, and constipation, when we get into the meds, we will discuss the importance of how we should try and avoid constipation, because it can actually influence the ability to absorb your medications to combat some of these symptoms. Swallowing disorders generally come at the later stages of disease, but they are important to be aware of because of the risk of choking, of course. You know, it's not difficult to think about what sorts of strategies we might have around swallowing. Of course, cutting the food into smaller pieces, and if necessary, even pureeing or purifying the food, liquefying the food is always possible. Pain is a common symptom. Often we'll have former football players or athletes saying, "Oh, I've had a stiff shoulder for many years before Parkinson's," and in fact, sometimes it actually is not an old sports injury, but actual Parkinson's disease. Some of our research has pointed towards decreased sensitivity, and cutaneous sensitivity refers to the idea that you may not be able to sense with your fingertips or toes the things that you used to be able to feel. For example, if you were to put your hand in your pocket to feel for a quarter or a dime or a nickel, perhaps with Parkinson's it becomes more difficult to use your fingertips without vision to sense what's in your pocket. The last one on here is a fairly important one, because with almost any neurological disorder, the brain has this backup mode of choosing to rely on vision to help guide how we move. And it's important to be aware of visual dysfunction that can be related to Parkinson's, because sometimes if the view of our environment is inaccurate, or we're unable to judge what we're seeing in our environment, then of course perhaps the body puts on the brakes because we're not sure what we're actually seeing or how far away it is, the object that we might run into or crash into while we're moving around in our environment. Linked to this idea of inactivity, the other thing to be aware of with Parkinson's is the potential link to cardiometabolic disease. It is important to note that Parkinson's disease really doesn't change your expected lifespan. So you're not expected to die any earlier with the diagnosis of Parkinson's disease. If you were meant to live until 80, you will likely still live until the age of 80. It's just that you'll see a progression of these symptoms of Parkinson's, the bradykinesia, rigidity, postural instability, and these sorts of symptoms that we talked about initially. What is important to realize, though, is that if we start to become less active because we're worried about falling, going outside of our home, or perhaps in the ice and snow, we are worried about our balance and potentially falling. Maybe the person doesn't want to have their tremor seen by other people, so they tend to stay indoors more. When that happens, of course, there are other physical symptoms that can result. And so we've got this other circle of increased weight, increased aging process, hyperlipidemia, late onset diabetes, and these can all be consequences of physical inactivity that can actually lead to more serious consequences than Parkinson's itself. Okay, the next topic that we are supposed to talk about is who can actually get Parkinson's, and then of course we'll try and get to diagnosis from there. The number one risk factor, the most important risk factor for Parkinson's disease is age. In fact, every 1 in 400 people over the age of 60 years old is diagnosed with Parkinson's disease. More importantly, perhaps, is the idea that for every decade of life, there's actually an increase in the rate of Parkinson's, or the incidence of Parkinson's. So by the time we get to 70 years or older in the Canadian population, it's 1 in 70 rather than 1 in 400 people that are being diagnosed with Parkinson's. And as we get to the age of 80 or older, it's actually 1 in 40 people. And of course, you can think about this in many ways. Perhaps there's less people to be compared to, but in general, what we're saying is that the frequency of Parkinson's certainly increases per every decade of age. This brings us to the question, and it's sort of a research question, the question of what really is that link to aging? Is it possible that with Parkinson's disease, the degeneration that we're seeing might actually represent a form of accelerated aging? And you can think about it like this. Perhaps if you were to look at a 60-year-old person with Parkinson's disease, might they look the same as a healthy person who is 90 years of age, but moving slowly because they're obviously 30 years older? And so if you had more of a stooped over posture, walking more carefully, walking with slower steps, slower to get dressed, all of those sorts of motor symptoms might seem like the normal expected movement pattern for somebody who's 90 years old, and perhaps somebody who's 60 years old with Parkinson's might actually move the same way with these sorts of motor deficits. Similarly, we could also think about cognitive decline, and of course cognitive decline is common as we continue to age. So things like memory, confusion, hallucinations, and even dementia. This is something that we're studying right now. It is common with older age, and again, it could be possible that maybe Parkinson's seems like a form of accelerated aging, that these symptoms start to show up earlier. The third set of symptoms that is linked to aging is, of course, bladder control problems, constipation. We talked about cardiovascular issues. As I mentioned before, if we become less physically active, there's more likelihood of cardiovascular issues being likely to present themselves. The next risk factor is gender. We used to believe that Parkinson's affected males and females relatively equally, but as we've gotten more accurate in our diagnosing of the disease, it appears that 3 out of every 5 Parkinson's patients are males, so that basically means it's closer to a 60-40 split, 60% males and 40% females who end up with Parkinson's. And then locally, we could talk about a few different causes or known things that are related to Parkinson's disease. And I should start by saying that most cases of Parkinson's are considered idiopathic, and idiopathic is just a fancy word to say that really most of Parkinson's comes from an unknown origin. Idiopathic means unknown origin. However, we can look at some of these hints towards causes of Parkinson's. Infectious disease, so people who have had von Economos encephalitis, 80% of them appear to develop the shaking palsy as described by James Parkinson. We could look at cases of metal intoxication. There are certain professions that require the workers to handle manganese, something like hydro workers, for example. And metal intoxication is a known cause of Parkinson-related disorders. Perhaps the most promising cause of Parkinson's is what we call a drug-induced form of Parkinson's, MPTP. For simplicity's sake, let's just consider MPTP a form of overbaked heroin. That'll be the simplest way to describe it. And of course, in this case, the toxin attacks the basal ganglia and results in very quickly developing Parkinson's symptoms. There is a genetic component to Parkinson's, and of course this depends on the study. 15 to 40%, depending on which study you look at, of Parkinson's can be explained by genes. There are close to 20 different genes that have been identified at this point that have been linked to Parkinson's disease. There are environmental toxins. We already talked about metal intoxication being one of them. Insecticides is something that we also look very carefully for. Rotenone insecticide, for example, is no longer used in Canada and is an identified neurotoxin. Okay, the next thing we're going to talk about is diagnosis. How do we know if we actually have Parkinson's? We used to say that there was no laboratory tests for Parkinson's, and this has been updated that there's actually one test, and we're going to talk about this in a moment. What we can say, though, is that on autopsy, we do recognize that there's an accumulation of a specific protein called alpha-synuclein in the brains of people with Parkinson's. So that is certainly a hint. We don't necessarily understand why the protein accumulates, but clearly if you do have an accumulation of alpha-synuclein protein, the symptoms of Parkinson's are generally there. Since we don't have laboratory tests for the most part that can diagnose Parkinson's, we depend upon our clinicians, our neurologists, and we often recommend that if you suspect that you have Parkinson's or you're dealing with Parkinson's, that you see a movement disorders specialized neurologist. A neurologist will evaluate the presence of 2 of the 4 cardinal motor signs that we described before. So just to review, that was the tremor, rigidity, akinesia, bradykinesia, and postural instability, those types of symptoms. We basically need to see 2 of those 4 cardinal motor symptoms to lead us towards a Parkinson's diagnosis. In addition to that, your physician will look for the non-motor symptoms that are common to Parkinson's. And while there's no blood test available to identify something like Parkinson's, over the last 10 to 15 years, we have developed some neuroimaging techniques that get us closer to being able to identify Parkinson's on a brain scan. Most often, if we do an MRI scan or something like that, MRI scans generally allow us to rule out other potential explanations for the motor symptoms that we're seeing. However, in the case of SPECT DAT scans, we can inject something like a radio-labeled iodine, and this allows us to be able to track basically dopamine transporters in the brain to see if the basal ganglia are functioning normally. So this type of scan, it does help us distinguish Parkinson's disease, or Parkinsonisms at least, from other similar disorders like essential tremor. Essential tremor is more of a genetic tremor disorder, and hence it runs in families. But these scans aren't all that great at separating different types of other Parkinsonisms. So Parkinson's disease is one form of many other Parkinsonian syndromes, things like multiple systems atrophy, progressive supranuclear palsy, corticobasal degeneration. All of these sorts of disorders, they're usually much worse than Parkinson's and they progress a lot faster. And unfortunately, these DAT scans aren't very good at separating these different types of disorders from each other. What I can show you, however, is what one of these scans would look like. If you look here on the left, the area that you're seeing in orange, red, and white that stands out in the center of the image is the image of the basal ganglia, or the dopamine transporter identified in a normal, healthy person that does not have Parkinson's disease. In contrast, if we look at the brain image on the right-hand side, you can see this is a person that does have Parkinson's, and you can see that that dopamine transporter is not showing up all that clearly at all, which hints to the fact that there's a shortage of dopamine functioning neurons in the center of the brain. Okay, the next topic we should talk about is, of course, treatments. And as you probably would guess, if we have a shortage of dopamine in the brain, one of the things that would make sense to do is try and replace that dopamine with a synthetic form of dopamine. And so we have things like levodopa, or perhaps your prescription is for something called apolevocarb. That's a generic form. You may also have heard of it as Sinemet, Sinemet CR, or Prolopa. These are all essentially the same base type of treatment. They're dopamine replacement drugs. These drugs are in the class that basically mask the symptoms of Parkinson's disease, but it is important to note that they don't actually stop the degeneration. They are very effective in Parkinson's disease, and it is considered the gold standard of treatment for Parkinson's disease. And notably, they are most effective for treating 2 of the 4 or 5 primary symptoms that we talked about. Slowness of movement certainly improves, as well as that rigidity or stiffness that can sometimes be detected by a clinician. And as I said, this is our #1 form of therapy. So if we think about how these medications work, and this slide may be a little bit busy to try and understand, but the basic idea is that we all should be trying to expect this level that's here in green. This green level is supposed to be the good level of dopamine that's supposed to be in our system. And if we have this amount of dopamine in the system and we're floating, the white line is supposed to represent how much dopamine we actually have in our brain. Most of us would expect a reasonably flat line of how much dopamine we have in our system, and hence we wouldn't see any movement symptoms. With Parkinson's disease, of course, our levels are much closer to this purpley bluish color at the bottom. And so when we take a dopamine supplement in the form of one of the pills that we just named, every time we take one of those pills, you can see a sudden increase in the dopamine content. And unfortunately, over time, over 3 or 4 or 5 hours, the amount of dopamine starts to wear off. And as you can see by this arrow here, this is a hint as to when the person is taking their next meds, about 4 hours later, and the dopamine levels increase. And over the period of 4 hours, those meds start to wear off again. And you can see that this is a continuous cycle during the day. So the important thing to note about this graph is that when we get to these bottom levels, if we start to stretch into the blue area, this means that, of course, we are going to start to notice symptoms returning. And this is why I say that symptoms are essentially masked by treatment with dopamine replacement agents like levodopa. But it doesn't necessarily get rid of the underlying mechanism of degeneration in the first place. On the flip side, we do have side effects that we could worry about in some cases, that when we take our dose of levodopa replacement or dopamine replacement, if this peak of dopamine in the bloodstream crosses into this red area, we suffer from a symptom called dyskinesia, which I'll show you in a moment. But dyskinesia is essentially turning up the volume or the amplifier of our movement system too much. And when that happens, of course, we end up with excessive movements, lots of jerky, functional type movements that can in some cases be more problematic than the symptoms of Parkinson's itself. So, what we have to think about is the effectiveness of our treatment. And in the early stages of Parkinson's disease, in the first 3 to 5 years that we're noticing motor symptoms, we have this giant window, and you can see this in the kind of grayish green color here, that we have this very wide window where once we take the meds, we have some effectiveness of this meds, and there's no real fluctuations. The meds seem like they work all the time, and patients will even say, I could go without taking meds for 4, 5, 6, 7, or 8 hours, and I still feel like the meds are working in my system all the time. This is generally what we call the honeymoon period in the first 3 to 5 years of disease, where the frequency of the medication doesn't necessarily change when the symptoms start to reappear. Over time, you'll notice by the narrowing of this grayish green window that over time, as the disease progresses, there starts to be more of this fluctuation idea where sometimes the peaks go beyond the acceptable level, and that's what leads us to dyskinesia. And at the same time, we can have these valleys where the meds go below the effective range, and we're trying to stay within this green area right here so that the symptoms are treated. And if we go beneath that, as you can see with this little area here and also here, that would be where symptoms are starting to return. In the advanced stages of disease, these ups and downs, the extra dyskinesias or the extra movements, and the periods where the meds start not to work become more frequent. So basically what we're talking about here is the amount of, your physician will refer to it as off time. And the off time is basically the amount of time that you're spending down here without any med effect to help you mask those symptoms. On the top side, we have dyskinesia, and every time we go above the level of effectiveness of the pills, in this top side, we would be suffering from dyskinesia type issues. Now, it is important for me to express that these types of what we call motor fluctuations, the peaks and the valleys linked to the meds, this isn't necessarily to be expected for everyone. In other words, we shouldn't expect that everybody's going to suffer from dyskinesia and everybody's going to suffer from off times. With proper clinical management and the supervision of a neurologist, we should be able to adjust the meds accordingly so that we can avoid all of these peaks and the valleys down below. And there's multiple strategies which we're going to talk about to try and deal with these motor fluctuations. This is just to show again that we're trying to avoid these the peaks at the top and the valleys at the bottom. The valleys at the bottom, of course, are where more symptoms would start to show up. The peaks at the top are, of course, where dyskinesia starts to show up, the excessive movements. So, if we add to this now, as I said, this is just a repeat of before. Dopamine replacement therapy is the gold standard. We do have other strategies to try and deal with the symptoms of Parkinson's. We have a second category of meds called dopamine agonists. So the more common names that you may have heard of already would be something like Requip or Ropinirole, Mirapex, Pramipexole. And there's even a patch form known as Retigotine. That can be a patch that you put on different parts of your body every day. And dopamine agonists, for simplicity, we could consider them essentially like sponges that help delivery of the dopamine. They allow the dopamine to enter the cells more readily. So basically, we're talking about influencing the receptor activity of dopamine, but it doesn't actually replace any shortage of dopamine. Hence, it's generally not as effective as our gold standard treatment, which is dopamine replacement. But they are there as a potential option that can be used in addition to dopamine replacement therapies. Or in some cases, if you're very young, we might try and work with a dopamine agonist first before getting to dopamine replacement therapy. This is, again, is something that you should discuss with your physician. The third category of drugs is inhibitors. There's two types of inhibitors that we could talk about. There's COMT inhibitors and MAO inhibitors. Basically, inhibitors are there to slow the breakdown of dopamine in the system so that the effects of the meds can last longer without these wear-off periods. So often participants, people with Parkinson's will take something called Comtan or entacapone, which is a COMT inhibitor, and it slows the breakdown of dopamine so that your meds don't wear off so quickly. There is, in fact, even a drug where the entacapone and the levodopa is combined into one single pill called Stalevo, in which case, the same sort of effect is there as taking one yellow levocarb pill with one entacapone pill. The second class of inhibitors is something like Azilect or Rasagiline, which is a monoamine oxidase inhibitor or MAO inhibitor. These are also said to slow the breakdown of dopamine, but importantly, we also tend to think of things like Azilect as potential neuroprotective agents, in the sense that they might actually be rust inhibitors to the neurons for, again, for simplicity's sake. So there are studies that have shown that there's potential slowing of the progression of Parkinson's if you're on something like a monoamine oxidase inhibitor. Probably one of the most important things we should think about when we're talking about treatment is the fact that the medication benefits really depend on the individual. As you know, Parkinson's is a progressive disorder, and since the symptoms change over time, it sort of depends on which symptoms you're dealing with. In some cases, there are symptoms that don't respond to meds, and in some cases, we can have other issues related to too much medication, and we talked about dyskinesia already. But there can also be other issues like postural hypotension and poor overall blood pressure control. Those are important things to make sure your physician is aware of. Okay, when we're talking about responsiveness of medications, there are some symptoms, and you can see I've put a small list of them here. In some cases, tremor doesn't seem to respond very well to dopamine replacement agents. In other cases, as I mentioned, sometimes balance and falls and postural instability issues can be related to having too much medication. And there are some studies out there that show that, well, at least suggest that balance may not improve with dopamine medications at all. The third debatable symptom as to whether it responds to medication is freezing, those issues where you feel like your feet are glued to the ground. And in some cases, even when we increase the meds, patients will report that the freezing behavior doesn't actually change. As I've been hinting, in most cases, it is critical for you to be working with your physician to be able to optimize how your meds are being used. If they are not being well managed, then of course we have these other issues that we can start to worry about, things like wearing off with prolonged use, motor fluctuations, difficulty trying to maintain that optimal dose, and avoiding things like dyskinesia. As I mentioned, dopamine agonists are not as effective, but they are an alternative to dopamine replacement. In some cases, they have been associated with addictive and compulsive behaviors, and some of them have been already taken off of the market for issues with heart valve dysfunction. Regardless of what medication strategy you are using, it is important to think about what other side effects you might actually be noticing at the same time. So I've listed here cognitive dysfunction. Sometimes memory and hallucinations can be the result of taking too much medication, or maybe just even starting on the medication. And it's important to communicate these issues with your physician. And I mentioned already the potential that sometimes balance issues can be related to blood pressure, and blood pressure can drop with some of these medications as well. So it's important to make sure that you're communicating that. Okay, so in this video here, if you look at this woman on the top, you can see that her feet are frozen, but this excess movement that you're seeing of her head and her arms and legs is that dyskinesia that we were talking about. This is the idea that with too much meds for a long period of time, we end up with excessive movement. Yet, you can see, even though she is medicated, the feet are most certainly freezing. On the bottom here, you can see a separate individual who's not treated with medication, and you can see the typical symptoms that we would expect to see with Parkinson's. You can see kind of a leaning forward or stooped posture. The man takes very small or short shuffling steps. There's hardly an arm swing, not much facial expression as he's walking, and walks very, very slowly and carefully. Okay, so if we're thinking about limitations, we've already talked about the idea of wearing off, the potential for motor fluctuations, dyskinesia, and now in addition to that, we should talk about a couple of things that have popped up recently. One is this idea of dopa-responsive dystonia. Dystonia is basically where you might feel something like a cramping in the back of the legs, or possibly your hand or your toes curling up, which we generally consider essentially warning signals that your brain is trying to tell you that you are due for another dose of your medication. And we say that they're dopa-responsive dystonias in the sense that when we take medications, then we start to see these symptoms to go away. So it's almost like a dinner bell trying to remind you that it's time to take your pills. In the last little while, there has been this issue with generic apolipocarb, which most patients with Parkinson's are taking right now because this brand name Sinemet happens to be in shortage right now. There are some people that report that the generic version of dopamine replacement isn't as effective. Most people don't really notice a difference between the two, but in people that are sensitive to the medications, the generic apolipocarb form of drug, which is a oval-shaped pill compared to the yellow circular Sinemet pill, may tend to be slightly less effective or wear off potentially a little bit quicker than brand name Sinemet. So this leads us to this bottom part, which is the idea of potential solutions. And again, these are things that can be managed with consultation of your physician. The idea of potentially increasing dosage of your medications as it becomes necessary, or in some cases, rather than increasing the dose, perhaps instead of taking a pill every 5 hours, you take a pill every 4 hours or every 3.5 hours if you're starting to notice that the wear-off periods are coming closer together. There's also the potential to use these COMT inhibitors, which we talked about, to stretch the effectiveness of the meds so that the wearing off isn't as noticeable. And within the last few years, there are other forms of delivery of dopamine agents. So there's a Ritery capsule. There's something called a duodopa pump, which pumps by drip through the stomach into the duodenum or the small intestine at a very slow rate so that we can basically mimic the production of dopamine that the brain would normally produce. There are some drawbacks, of course, to having a tube attached to your gut at all times. But when people are dealing with motor fluctuations and sudden off times, this does end up being a pretty useful solution. And as I mentioned, in some cases, there are things like a patch that can deliver constantly the medication through the skin. Okay. In addition to medications, there are also surgical options for the treatment of Parkinson's. There are surgical procedures where we can insert electrodes into the brain, usually with one of two targets, either the subthalamic nucleus, which is part of the basal ganglia, or the globus pallidus interna. We use brain scanning techniques like MRI or CT to try and figure out the exact location before the surgery, of course, to guide us to the right targets. And then once those electrodes are implanted, we can use electrical impulses that are sent from basically a pacemaker, which is embedded on the surface of the skin of the chest, to target and interfere with the signals of the brain that are causing the Parkinson's symptoms. Visually, this is what it would look like. So you can imagine the essentially like the pacemaker unit being embedded in the skin just below the clavicle here, this bone right here in the neck. And from there, if we have these wires that run up the back of the head and right up to the top and deep into the basal ganglia, the two targets in this basal ganglia, we can deliver an electrical current that allows the interruption of those signals that are causing the movement symptoms. So that is obviously an option as well, and we've made great advances over the last 15, 20 years in being able to target those targets very specifically, and there is lots of advances in being able to control the amount of voltage and the pulsing of the voltage to both the left and right side of the brain as is necessary. I do want to mention that Canada is very fortunate to have a team of researchers called the Canadian Consortium for Neurodegeneration and Aging that is working across the country to try and combat some of these issues with Parkinson's and even memory disorders like dementia and Alzheimer's disease, with exercise treatments, studying motor function and cognition. And these team members, of course, work across the country trying to figure out how to enhance our treatment of things like Parkinson's disease. So again, I'm putting up our contact information as we near the close of our talk. We're always looking for Parkinson's patients to be involved in our studies. The first term there, de novo, hints to the fact that it is extremely difficult to find participants that aren't on any medications. And sometimes when we want to attempt new treatment strategies, it's very useful to try and get participants with Parkinson's into our research facilities to try these new treatments before they've had any attempt with the medications. Of course, there are studies with medication as well. Research can also actually be done with and without the medications to make sure that we understand the effectiveness of the meds. We also look for participants with cognitive impairment, and even if you're a healthy control, it can still help towards that mission of understanding Parkinson's. The last part I want to talk about just very briefly is the idea of exercise. A lot of our research here at our Movement Disorders Center is focused on exercise. There is certainly a lot of research that supports in animal models that we can reverse some of the symptoms of Parkinson's if we induce it in mice and rodents. But the results don't seem to be all that conclusive in humans. We are getting closer, however, to identifying certain exercises. This is one of our own studies, and what you can see here is 4 different strategies for exercise, and the size of these purple bars represents how effective that strategy is at changing the symptoms of Parkinson's. Clearly, if you don't do anything at all, you can see that the symptoms actually end up progressing, and that's why this 1 bar is going in the opposite direction. all of these strategies do seem to have some effect, and there are certainly some strategies. PD SafeX is something that we've created here at our own center, but even strength training exercises, aerobic activity, and aquatic programs do have some benefit. So it is important to stay physically fit and active at all times. Okay, so I'm going to stop there. If there are any quick questions, I will see if our moderator has any questions for me to answer that have been sent over email, and I'd be happy to answer them.
Thank you, Dr. Almeida, for a great presentation. As of right now, I don't have any questions, but I know that you are very busy and you do have another meeting coming up. Therefore, if we can hold the questions actually for today and send them to me by email so I can forward them to Dr. Almeida, that would be great. My email is my first name, Caitlin, K-A-I-T-L-I-N.Garbutt, G-A-R-B as in Bob, U and 2 T's, at parkinsonsociety.ca. Just want to say thank you again for everybody for coming out, and I wish each and every one of you a wonderful day, and thank you again, Dr. Almeida, for being available today, and we look forward to hearing you and all your exciting research in the future.